Hello everyone, welcome to Dental Matters. In this episode, we will be dealing with the questions that all of you have put forward on the topic diagnosis and treatment protocols in periodontal therapy. The first question that we have received is biologic width concept in CLP, that is crown lengthening procedures. So what you understand by biologic width, it is nothing but the combined dimensions of the connective tissue attachment and the epithelial attachment, or to make it simpler, it is a dimension of soft tissue which is attached to the portion of the tooth coronal to the crest of the alveolar bone. So in terms of measurement, when you probe from the gingival sulcus, the dimensions of the biologic width are approximately 2 millimeters, 2.04 millimeters plus the depth of the sulcus. So from the margin till the crest of the bone, ideally the biologic width is around 3 millimeters. 1 millimeter for the sulcus, 1 millimeter for the junctional attachment, and 1 millimeter for the connective tissue attachment. So this dimension and this entity is important in planning your restorative procedures, wherein the margins will go subgingivally. So you are expected to keep a safe margin of approximately 3 millimeter between your restorative margin and the crest of the bone in order to prevent invasion of this physiologic entity. Otherwise there will be outcomes like persistent inflammation around your crown, or there will be gingival recession. Taking up the next question, is bone grafting successful in diabetic patients? The purpose of using a bone graft is to fill up a defect of bone in order to maintain clot stabilization, in order to maintain the shape and geometry of the defect, to prevent collapse of soft tissues, and eventually the aim is to allow that bone graft to maintain space so that it eventually converts into new bone. It's a metabolic condition, so they have some changes in the collagen synthesis, maturation, turnover. Then there is a gingival fibroblast productions, and formation of collagen is reduced. Also there is something called as advanced glycation end products which are formed. So these glycation end products cause cross-linking of the collagen basically. So weak collagen stays in the body longer, new collagen is not formed, and old collagen stays longer. So basically what happens is the wound healing is altered. So eventually when you use any surgical procedure or perform any surgical procedure in diabetic patients, there is always a chance of altered or delayed wound healing because of these problems. Also the neutrophil functions is affected, so post-operative infections can be common, and that's why most of the times we do any patients who are diabetic, you do the surgeries under antibiotic cover. So bone grafts has no direct relation with diabetes, but yes, it is a part of a surgery. So naturally the way healing is altered or delayed in diabetic patients, the turnover or rate of turnover of bone graft may be affected depending upon the status of diabetes.